Hi, everyone. I hope you are enjoying the summer. This is Dr. Amigues, your friendly rheumatologist. For those of you who do not know me, I'm a rheumatologist. I'm French. Originally, I've done rheumatology in France. And then I did everything. Was well trained in rheumatology in Paris and then Lyon. And then I moved to New York City, where I repeated my residency and my fellowship at Columbia University because I really do love rheumatology. Then I came to Denver and I was at National Jewish for a little more than 5 years, where I did a lot of research in interstitial lung disease. And then, because of my own history with stage 4 breast cancer, decided to actually open a direct care practice that I have that's called OnAbridge MD. And I'm really passionate about the type of care that I offer through OnAbridge MD. But I also love to educate people. And so those Rheumatology 101 are for education purposes. So again, I don't give medical advice when I'm doing those, but I'm happy to answer really like a lot of questions. And so this is one of the most commonly asked question, which is, how do you differentiate rheumatoid arthritis and osteoarthritis? And let me, as always, give you an example from a patient. So I had a patient the other day that came to me with joint pain. And she had been told by many other doctors that she had most likely osteoarthritis, which is what we call wear and tear of the joint. And she came in and basically she was like, I want a second opinion because I'm just not sure that that's what it is. And I want to make sure of what there is to do. And there were a couple of questions I asked her, and we will go into this. And then, you do an exam, and it turned out that she had actually a little bit of both. She had osteoarthritis and she had rheumatoid arthritis. So what is rheumatoid arthritis, and then what is osteoarthritis? So rheumatoid arthritis is an inflammatory autoimmune disorder that affects mostly the joint, and that's why you have joint pain, but can really affect all of your organs. It can affect the lungs, the eyes, the skin, the lungs, I've already said that, the heart, and you can even have fever, like when it's really severe. But usually where you find it the most is in the joint. And rheumatoid arthritis is very inflammatory. And so you're going to have an inflammatory type of pain. Pain, as you always, if you followed me, worse in the morning, associated with morning stiffness. So you feel like you have to do this for 30 minutes or more. And with swelling of the joint. And the swelling is not a bony swelling, but it's soft tissue swelling. And the swelling is worse in the morning. When you have that and it's symmetric, and it's affecting the MCPs, which are those knuckles, the PIP, which are nose knuckle, does not affect those distal one. So that's called DIP. Rheumatoid arthritis does not affect this. When you have those knuckles, the first two ones, you have the feet. Rheumatoid arthritis loves the feet, loves the shoulders. When you have this, you have to think of rheumatoid arthritis. And so then usually what we do is that we do rheumatoid factor, CCP, we check those serological markers. If they are positive, that gives you another argument for rheumatoid arthritis. And we also look at the x-rays, and I always do the joints that are painful, but so the hands for sure, and also the feet, even if they are not painful, the feet, because you can have erosion of the head of the fifth MTP, which is the little toe, but at the base. And that is a very good argument that this is rheumatoid arthritis. Okay. And so then the way we think is this rheumatoid arthritis seropositive? So is there rheumatoid factor, CCP positive? So those antibodies. And is it erosive? Is there any erosion? So if you have erosion, even just of the fifth MTP, the little toe, the base of the little toe, then you know that you have an erosive rheumatoid arthritis. You're gonna treat a little bit more aggressively, because we know patients who are seropositive and or erosive have more chance of having more severe disease, and the goal is to put you in remission as fast as possible. That's the rheumatoid arthritis in a nutshell. Osteoarthritis, on the other hand, is what we call wear and tear of the joint. It's actually a lot more complex than that, but we don't know much. So we know a lot about rheumatoid arthritis. We know much less when it comes to osteoarthritis. What we know is that if you do repetitive movement, so for example, when you're doing cell phone and you're texting constantly, as you can see, I am one of them, you develop osteoarthritis of the base of the thumb and this one, right? The CMC and the base of the thumb. And what's happening is that the repetition can wear your joint. So if you're someone that's using your joint a lot because you're doing some woodwork all of the time, because you're a manual worker, because you're a cleaning person, that you're using a lot more your joint and you're putting a ton of pressure on them, you have more chance of developing osteoarthritis. The truth is that it's also genetic. So if your mom or your grandma had those knuckles with like nodes, and usually it's at the end, like, you know how I was telling you rheumatoid arthritis does not affect those joints, the DIPs? Well, osteoarthritis loves those joints to the point that we have a term for those nodes. It's called the Heberdine's node. For fellows, Heberdine is H, it's far away. B for Bouchard, this would be the nodes, and it's closer, right? So I think that there's like a bus mnemonic, I don't find it, but Bouchard is close, it's B, and Heberdine is far, it's H. But yeah, those nodes will affect osteoarthritis can cause remodeling of the bone, because basically when you are developing the osteoarthritis, the first thing that you're developing is that you're losing the cartilage, and then your body is trying to make up that cartilage, but it cannot remake the cartilage. So it's making bone. The problem is by making bone, they're creating bone that shouldn't be there. And that's why you have the nodes, the Bouchard and the Heberdines. And so that is why you're developing those. And that's why, you know, when you're feeling creaky, there's like some crackles feeling of your knees when you're getting up and down. That is because your body has created some bones, because that's the only way they can recreate some sort of cartilage, but it's not cartilage, and it doesn't work like cartilage, and it actually causes potentially harm to have all of those what we call osteophyte, which is osteophyte creation of the bone, osteo. The arthritis is more mechanical, and what it is that it's a pain that's worse towards the end of the day. It's worse when you're using it. And the morning stiffness is less than 30 minutes. And usually it's like 5 minutes just to get things going, but it's not more than 30 minutes, never. If it is more than 30 minutes, you have to think of an inflammatory arthritis. So already you're thinking, okay, so rheumatoid arthritis, inflammatory type of pain, osteoarthritis, mechanical, the more I use my joint, the worse it is. So that's already something that you can divide. And then when you're looking at the patient, when you're looking at your symptoms, you have involvement of the MCP and PIPs for rheumatoid arthritis. For osteoarthritis, you're going to have involvement of the DIPs and the PIPs. Usually you do not have involvement of the MCP. And then you can have crackle, like you can have like noise, like, and that, you know, that it's osteoarthritis. Now, here is the thing that's tricky, is that you can have rheumatoid arthritis that leads to osteoarthritis. And so when patients have had rheumatoid arthritis for a long time that was not properly treated, they can actually develop osteoarthritis. And so you can still have the creaky, you can still have the osteophyte, but it's basically a complication of this inflammatory arthritis that was not properly treated, okay? Because the endpoint of inflammation that's destroying the joint is osteoarthritis, and that's where it becomes tricky. So how did I make the difference of this patient when I said she had both? She had osteoarthritis and rheumatoid arthritis. Well, a couple of things. One, the easy part is that she had CCP that was positive, rheumatoid factor that was positive, easy. But then you could say, oh, well, she just had rheumatoid arthritis. I'm like, no, she didn't just have rheumatoid arthritis, because on exam, she had Bouchard. So she had both synovitis, so inflammation of the joint. That was like the soft tissue. You can, like, it has like this rebound feeling when you touch it. Whereas the bone doesn't have a rebound, just like it's just big. And so it had that. And then the other thing is that she also had Heberdine's node. And then on X-ray, we could see involvement of her, like it was both like an inflammatory arthritis type of erosion. And she also had evidence of osteophytes, which is related to osteoarthritis. And that's really how we make the diagnosis. Now, the thing is, how do you treat? Well, the most important in her case was to treat the rheumatoid arthritis part, because you can put a patient in remission from a rheumatoid arthritis standpoint. And until you have taken care of this, it's really hard to take care of the osteoarthritis part. When it comes to osteoarthritis, so we put her in remission from a rheumatoid arthritis standpoint. So she had no more swelling, that like the rebounded swelling, the soft tissue swelling. She had no more morning stiffness, or it was less than 5 minutes. And she had no more pain that was worse in the morning. What she had was pain that when she was using her joint. What we do when we have to deal with the osteoarthritis then is that we may actually need to do surgery if there is such destruction of the joint that we have to do that. But the truth is that this patient has done very, very well with just being treated for rheumatoid arthritis. And a lot of the pain that we thought was also related to the osteoarthritis actually went away after treating a rheumatoid arthritis. And so right now she's in full remission, doing really, 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 really well. And that is really how you make a diagnosis between rheumatoid arthritis and osteoarthritis. So I hope this was helpful. Again, the most important thing always is to remember that osteoarthritis is the endpoint of rheumatoid arthritis, but and can also be primary. That the way you differentiate between an inflammatory arthritis and a mechanical arthritis, such as osteo, is to just ask those questions. Is the pain worse in the morning, associated with morning stiffness? Is it improved with exercise? And is there swelling, that soft tissue swelling? If there is yes at any of those questions, you're looking at probably an inflammatory arthritis. And then you treat the rheumatoid arthritis, you treat the inflammatory arthritis, and you aim for full remission. Then you can take care of the osteoarthritis afterward if there is still some pain. But yeah, so I think that's it. Thank you so much, everyone, for looking at those lives. I'm going to take a break for 2 weeks. I'm seeing my parents and I'm bringing my kids with me in France. And so while I will be working for my patients, I'm taking a break from the YouTube Rheumatology 101. As well as from my podcast on Amigues MD. But I will be back in 3 weeks, and you can ask me questions. You can ask me all the things that you want. I'm looking at them and I decide what topics to talk to. You guys always have incredible good topics to discuss. So please, please, please let me know what you would like to discuss. And then if you find those helpful, please share them. This is how we put more information out there in the world. And I feel like there's so much information from not doctors, and I think it's time for doctors to have some information out there. Have a wonderful week, actually a wonderful more than 2 weeks, and I will see you when I get back. Take care, everyone. Bye-bye.